Welcome, everybody. My name is Nick Barker. I'm our bite-sized lecture coordinator. I'm a clinical pharmacy coordinator at Emory St. Joseph Hospital in Atlanta, Georgia. Before we get started and I introduce our speakers today, I want to make sure that I read our mission statement. Is to emulate SECM's mission, which is to secure the highest quality care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. I'm super excited for our speakers today. They're going to be talking on Beyond the Benzos, current inpatient strategies for alcohol withdrawal syndrome. I'd like to welcome our speakers. First, Cassidy Ruckle, PharmD, BCMP. She's an emergency medicine clinical specialist at Baptist Memorial Hospital in Memphis, Tennessee. She obtained her Doctor of Pharmacy from Lipscomb University in Nashville. She then completed her PGY1 residency in Iskanzi Health in Indianapolis. She followed this by PGY2 in emergency medicine at Methodist in Memphis. She is a co-course director for the emergency medicine elective at the University of Tennessee. She also precepts students and residents at her practice site. Thomas Shapaker is a PA in critical care at Baptist Memorial Hospital in Memphis. He obtained his master's in physician assistant studies at Bethel University in Paris, Tennessee. He is the critical care APP manager at Memphis Lung Physicians at Baptist Memorial Hospital, and he precepts PA students from multiple universities in the surrounding area. And finally, Dr. Jeff Wright is a critical care and pulmonology attending for the Memphis Lung Physician Group, as well as Baptist Memorial Hospital in Memphis. He attended Rhodes College, graduating with honors in chemistry. He attended graduate school at Northwestern University and medical school at Vanderbilt. He pursued biochemistry research at Yale, where he was awarded an American Cancer Society postdoctorate fellowship. After medical school, he completed his residency and specialty medicine fellowship training at Vanderbilt. Upon completing this, he became a member of the St. Thomas Medical Group in Nashville. While he was there, he started one of the region's first clinics devoted to lung cancer. His primary interest is patient care. He also serves on the board of directors for Select Health Alliance and the Baptist One Care Physicians Advisory Council. His professional memberships include the American College of Chest Physicians, American Thoracic Society, and the Society of Critical Care Medicine. I'd like to welcome our speakers today. I'm going to let you guys take it away.
Thank you, Nick. Thank you, everyone at Southeast Chapter, to allow us to put on this bite-sized lecture today titled Beyond the Benzos with the Current Inpatient Strategies for Alcohol Withdrawal. Disclosures, we do not have any conflicts of interest to disclose. And the objectives today are to identify the etiology and risk factors associated with alcohol withdrawal syndrome, compare and contrast the current pharmacological treatment options for alcohol withdrawal syndrome, and evaluate the recommendations for supportive care treatment in alcohol withdrawal syndrome. So we'll start out with a case presentation. 40-year-old male admitted with a complaint of leg numbness and unsteady gait times 2 weeks. Patient reports taking 6 shots of whiskey per day. Last drink was 1 day prior to arrival. Past medical history of hypertension, hyperlipidemia, kidney stones, obesity, and alcohol abuse. Lab showed sodium at 121, potassium 3.5, chloride 81, bicarb 23, BUN 18, serum creatinine 1.69 with glucose of 117, with a MAG of 1.7 and a FOS of 2.4. The overall beginning of the hospital stay started on day 1 in the ED, where you started on a chlorodiazole epoxide, thiamine, folic acid, normal saline with potassium chloride, lorazepam, magnesium, and potassium chloride. Day 2, addiction medicine was consulted. Patient reports he started drinking at 16 years old, and it escalated in college, 1 handle of whiskey every 2 weeks. After college, escalated to 2 to 3 handles every 2 weeks, especially increased when COVID happened. September 2020, self-tapered, leading to hallucinations and seizures. Day 3, patient was transferred to the ICU, was initiated on a Precedex infusion with half normal saline with the potassium chloride. And on day 4 and beyond in the ICU, patient remains confused, hallucinating, with tremors, and enjoyed listening to the 90s country music. Epidemiology. About 10 to 20% of the population will develop an alcohol use disorder. It costs roughly $249 billion spent annually in the United States related to alcohol use disorder. And there's a huge impact on inpatient hospital care for patients who develop alcohol withdrawal syndrome. So DSM criteria for alcohol withdrawal syndrome includes a cessation of or reduction in alcohol use that has been heavy or prolonged, 2 or more of the following developing within several hours to a few days after the cessation of or reduction in alcohol use described in criterion B. Autonomic hyperactivity, increased hand tremor, insomnia, nausea or vomiting, transient visual, tactile, or auditory hallucinations or illusions, psychomotor agitation, anxiety, generalized tonic-clonic seizures. Other things to think about: the signs and symptoms in criterion B cause clinical significant distress or impairment of social, occupational, or other areas of functioning. And these signs or symptoms are not attributable to another medical condition and are not better explained by another mental disorder, including intoxication or withdrawal from another substance. So the pathophysiology. So under normal physiologic conditions without alcohol consumption, there is a balance between our inhibitory GABA and our excitatory glutamate NMDA neurotransmitters in our brain. In acute alcohol ingestion, alcohol acts as a CNS depressant due to the disruption of 2 or more of the major transmitter pathways, i.e. the inhibitory GABA A receptors and the excitatory glutamate NMDA neurotransmitters. Where we see the majority of the effect of alcohol acting on the GABA A receptors as an agonist, where we see increases in inhibitory tone within the brain and inhibition of the excitatory glutamate, leading to CNS depressant effects. Chronic alcohol ingestion leads to a tolerance where we see conformational changes, where we see downregulation of the GABA receptors and upregulation of the glutamate receptors to maintain balance. Due to this, patients with chronic alcohol ingestion require that constant presence of ethanol to achieve that CNS balance to prevent withdrawal symptoms. And these patients often develop increasing tolerance over time to ethanol, requiring higher blood alcohol levels to achieve clinical intoxication. Due to this, patients' abrupt cessation or reduction of alcohol intake reveals that brain overactivity as it tries to readjust to the absence of alcohol. And now getting into the pathophysiology of our talk today, acute alcohol withdrawal. This develops when that balance between inhibitory and excitatory neurotransmission is disrupted due to the decrease in alcohol consumption, either due to abrupt reduction or cessation in alcohol. This results in a CNS hyperexcitation due to the deficient GABA activity and excess glutamate activity, leading to unregulated excess excitation as the primary physiologic abnormality we see here. And the CNS hyperexcitation, we see a release of catecholamines cause an increased sympathetic tone, which manifests as the initial symptoms of alcohol withdrawal syndrome. Next, we'll kind of get into the stages of alcohol withdrawal syndrome, starting with stage 1 at the 6 to 24 hours, where we see tremors, autonomic activity, insomnia, agitation, tachypnea, hyperventilation, headaches, sweating, anorexia, nausea, vomiting. Stage 2, around 7 to 48 hours, we see distractibility, tonic-clonic seizures, hallucinations, autonomic instability, and diarrhea. Stage 3, at 49 to 96 hours, patients can develop delirium tremens, severe autonomic instability, confusion, disorientation, and extreme agitation. And the diagnosis of delirium tremens, according to the DSM-5, includes a decreased attention and awareness with disturbances in attention, awareness, memory, orientation, language, visuospatial ability, perception, or all of these that is a change from baseline and fluctuates in the severity throughout the day. And disturbances in memory, orientation, language, visuospatial ability, and perception. So now we'll go over the CWA score. This is a clinical assessment tool for alcohol withdrawal. It stands for the Clinical Institute Withdrawal Assessment Scale for Alcohol, revised. And this has been the most studied and it's most widely used, but there are other scales that exist for alcohol withdrawal. The scaling system helps nursing staff determine the need for medically supervised withdrawal management. For patients with a history of recent alcohol use who are able to communicate symptoms to their medical providers, the CWA scale can be used to guide that treatment. And we've seen randomized clinical trials that have shown that the use of the scale and the treatment of alcohol withdrawal reduced the total amount of benzos needed and shortened duration of treatment. Things to think about is the CWA should not be used to diagnose alcohol withdrawal. The scale does not include the prerequisite of heavy or prolonged alcohol use, and the constellation of symptoms it tracks are non-specific. CWAS should not be used to guide treatment when an alcohol history has not been obtained and or the patient cannot communicate symptoms. This can lead to inappropriate use of benzos, prolonging hospital stay. So the CWAS score is a 10 different criteria that we look at, including orientation, nausea, vomiting, tremor, proximal sweats, anxiety, agitation, tactile disturbances, auditory disturbances, visual disturbances, and headache, with a max score of 67. Here, based on the score, we kind of grade the CWA, with severe being greater than or equal to 16, moderate 9 to 15, and mild 0 to 8. Treatment strategies. Benzos have traditionally been the mainstay of preventing severe alcohol withdrawal symptoms, such as DTs and seizures. They can be administered using either a fixed dose schedule or symptom-triggered regimens. And when we have a fixed schedule or fixed tapering dose regimens used, the benzos given at a specific interval and additional doses are given as needed based on the severity of withdrawal symptoms. In a symptom-triggered regimen, a medication is only given when a symptom necessitates based on the alcohol withdrawal assessment scales we saw previously. Here we can see a protocol here at our local hospital in Memphis that we use to kind of dictate, based on the score, how much Ativan the patient receives with frequency of monitoring, including infusion. So kind of treatment overview, talking about the prevention of disease progression and relieving of withdrawal symptoms. All right, we'll start out with barbiturates or benzos, and then get into barbiturates, propofol, and Precedex. So here we can see the GABA receptor and benzodiazepine receptors, which are found on that postsynaptic nerve ending of the CNS and are part of the GABA receptor complex. GABA is the primary inhibitory neurotransmitters we talked previously in the CNS. GABA receptor complex is composed of 2 alpha and 2 beta subunits, and the alpha subunits are the binding sites for the benzodiazepines. Beta subunits are the binding sites for GABA, and there's a chloride ion channel located at the center of that GABA receptor complex. Here's kind of an overview of different benzos that we use: Librium, Valium, Ativan, different routes of administration with dosing ranges for PO, intermittent dose range, onset of action, half-life, and metabolism. So keep that in mind in patients with liver failure. Next, I'll hand it over to Dr. Wright to talk about barbiturates.
All right, so I'm going to touch on the barbiturates part of this talk. My junior colleagues were kind enough to give me the shortest part of the talk. So back to the GABA-A receptor. This is a ligand-gated channel receptor that is the principal site of action of gamma-aminobutyric acid, which is the principal neurotransmitter that's involved in alcohol. The site, as Tom talked about earlier, the GABA-A receptor ion channel complex is composed of 5 subunits, 2 alpha, 2 beta, and a gamma subunit. And unlike the barbiturates, the barbiturate binding site is on the gamma subunit. The mechanism of action for phenobarbital is that it enhances or activates GABA binding to the receptor and increases the duration of which the GABA channel, chloride channel, is opened, thus increasing the effects of gamma-aminobutyric acid. The onset is rapid in time, with about 5 minutes when given IV, peaking in about 30 minutes. It's nearly as rapid when given orally. The half-life ranges from 50 to 140 hours, depending on variabilities in the patient's Dosing typically ranges, and as we'll see in those different studies, between 60 and 260 milligrams IV. Of course, higher doses are associated with anti-seizure activity, although those of us old enough to remember when it was used regularly for seizures, 80 to 90 to 100 milligrams is typically adequate as an anticonvulsant. There is a dose-dependent, albeit somewhat unpredictable, respiratory depression associated with the use of phenobarbital. And sort of clinical pearls, it does have a low addiction potential. It's not commonly a drug of abuse. It's quite sedating, but because it's uncommon, it's not abused very frequently. And it's alleged to have synergistic effects when combined with benzodiazepines. So our first study to talk about with this was the use was actually a well done small randomized double-blind placebo-controlled study looking in the emergency department the use of phenobarbital together with a standardized lorazepam-based withdrawal protocol. The single primary endpoint of the study was ICU admissions from the emergency department. Drug was administered in the emergency department, and then the how many of those patients required ICU admission was used as the primary endpoint. There were 102 patients in the study, evenly split between the phenobarbital group and the placebo group. They were given a 10 milligram per kilogram IV dose times 1, and then placed on a symptom-triggered lorazepam-based withdrawal protocol. The placebo group just received the lorazepam alone. There was an impressive reduction in ICU admission rate from 8% to 25%. Excuse me, from 25% versus 8% in the intention to treat group. There was a decrease in the number of patients who required lorazepam continuous infusions, with only 4% of those receiving the phenobarbital requiring a lorazepam infusion versus 31%. Again, my own take on that is kind of a heavy-handed use of benzodiazepine infusions, but certainly these things vary from institution to institution. There was a decreased total lorazepam dose required, 26 milligrams versus 49 milligrams. Those of you who live in the critical care space will love the fact that we're giving less of a deliriogenic drug, which shows a clear dose dependence in these patients. And there was no difference reported in the adverse effects. So potential problems with this study is it was a single centered trial, so it would be nice to see a large multi-center randomized controlled trial. What is the optimal dosing of phenobarbital? And then finally, is there a cost-benefit analysis to doing it? Probably the answer is yes, there's a cost benefit by keeping the patient out of the ICU. Next study to talk about, this is Roberson's study from the American Journal of Emergency Medicine in 2020. This was looking at single-dose phenobarbital in addition to a symptom-triggered lorazepam study in patients that were admitted. Again, this was a retrospective chart review study. The inclusion criteria were that the patient was greater than 18 years old with moderate to severe symptoms. They received greater than 4 milligrams or more of lorazepam on the first day. And then they were excluded if they had other benzodiazepines on board, were given dexamethasone, or discharged within the first day. And they were also excluded if they were intubated on the first day. The patients received lorazepam if they had moderate symptoms, 2 milligrams, and severe symptoms, 4 milligrams, versus the phenobarbital plus the same lorazepam-based protocol. The primary outcome was the total dose of lorazepam given. The phenobarbital patients were received about the same amount, interestingly enough, of the lorazepam dose. However, the phenobarbital patients were more likely to be discharged within 3 days of hospitalization, which was a secondary endpoint. So again, what are the potential opportunities here? Certainly, it would need a larger multi-center randomized controlled trial. Again, what's the optimal dose of phenobarbital to give these patients? And then, as we'll see in the next study, is it maybe perhaps better to have multiple doses of phenobarbital? This is a head-to-head comparison comparing phenobarbital to a phenobarbital-based protocol to a lorazepam-based protocol. This is from Tom Tibbetts and Angela Canonico in Nashville, from kind of a combination of St. Thomas and Vanderbilt folks. This was published in 2018, the American Journal of Critical Care. This study was a retrospective cohort studies of medical ICU patients who were given either a benzodiazepine-based protocol for greater than 24 hours, and then yeah, that's kind of where we are. There were 120 patients in each total, 60 patients in each group. The primary endpoints were ICU length of stay and hospital length of stay. Secondary endpoints were invasive mechanical ventilation requirements and how much and what adjunctive sedation was required. There was an impressive reduction in both the ICU length of stay, 4.4 versus 2.4 days in the intervention group. So those patients receiving phenobarbital were in the ICU 2 days less. And their hospital length of stay was, again, equally impressively reduced to 4.3 versus 6.9 days. Also, I think important is to recognize that the invasive mechanical ventilation requirement was dramatically lowered in the phenobarbital patients, with only one of the 60 patients in that group requiring that versus 14 in the lorazepam only group. Adjunctive sedation, again, less requirement for that. Precedex was used primarily, but only 4 of the patients receiving phenobarbital required additional Precedex versus 17 in the lorazepam group. And I would say that we actually use this protocol here, and that kind of mirrors our own experience, is that we see much less mechanical ventilation in these patients and much less requirement for additional sedation. This is kind of an overview of the protocol. The patients were divided into 3 separate groups. If they had active DTs, they were given an IV loading dose of 260 milligrams of phenobarbital, followed by scheduled doses of tapering phenobarbital, starting at 97 milligrams 3 times daily for 2 days, followed by 64 milligrams, and then 32 milligrams. If they'd only had a history of DTs but were not actively in DTs, they were given a prophylactic treatment consisting of 97 milligrams for 2 days, 65 milligrams for 2 days, followed by 32 milligrams for 2 days. And if they had a strong alcohol history and concern for possible DTs, they were given a prophylactic regimen consisting of 65 milligrams followed by 32 milligrams for 2 days. So there were 120 patients in each of these groups, and as I said, this duplicates, but there were reduction in length of stay and hospital bidets by 2 days, less mechanical ventilation. So it appears, again, our personal practice reflects this, is that the use of phenobarbital is a very reasonable alternative to lorazepam for the treatment of alcohol withdrawal syndrome. It decreases the length of ICU and hospital stays. What's needed, again, as with most of these things, large multi-center randomized controlled trials are essential to establish an optimal regimen and really prove that this works across hospital systems. And then also trying to understand fully what the safety of the phenobarbital at higher doses is. Anecdotally, we've had some patients who were excessively sedated on the higher doses, although that's the exception rather than the rule. I think I skipped this. Yeah. This is a next study was basically phenobarbital versus lorazepam, and this was a retrospective cohort study. And this was actually for hospitalized patients who were not initially admitted to the ICU. So, and the endpoints was to study the hospital length of stay. It's a retrospective cohort study. The inclusion criteria were generous, 18 to 100 years old. And their primary hospital diagnosis was that of alcohol withdrawal syndrome. They were excluded if they were admitted to the ICU. Pregnant prisoners transferred from somewhere else. And interestingly enough, excluded if addiction medicine was consulted. This is a large study, 606 patients. But only 63 were in the phenobarbital protocol group, and the remainders were in the lorazepam based protocol. In the treatment group with phenobarbital, the length of stay was reduced from 2.8 to 3.6 days, so about a full day, with statistical significance. The all-cause 30-day readmission rate was reduced from 14 to 11%, again statistically significant. And the number of ED return visits within a month was reduced from 18.6 to 11.1%. So this is a hospital administration-friendly protocol. And with that, again, that would need a large multi-center trial. And again, showing that phenobarbital is a reasonable alternative to just lorazepam. And I'm going to pass this off now.
Thank you. Thank you, Dr. Wright, for the great review on phenobarbital. So moving on to the third and final part of this bite-sized lecture, we're going to discuss some alternative medications that can be used when taking care of patients with alcohol withdrawal syndrome. First, we'll start off with propofol and dexmedetomidine. So propofol, as we all know, is a GABA alpha agonist and NMDA glutamate receptor inhibitor. It has a quick onset and a duration that is relatively short of 3 to 10 minutes, which is why we frequently utilize infusions with this medication. Side effects include hypotension, increased triglycerides, and propofol-related infusion syndrome, also known as PRIS. Due to respiratory depression with this medication, patients must be mechanically ventilated in order to receive this medication as an infusion for those with severe alcohol withdrawal. Dexmedetomidine works in a different mechanism of action, working at the alpha-2 agonist in the CNS. It also has a relatively quick onset when used as an infusion, and a little bit of a longer duration than propofol at 60 to 120 minutes. Side effects include, but are not limited to, bradycardia, hypotension, and patients can also experience withdrawal, sometimes necessitating clonidine tapers to help get patients off the dexmedetomidine infusion. The biggest clinical pearl with dexmedetomidine is that this medication, since it does not work on any GABA receptor, cannot be used alone for alcohol withdrawal. It must be given with something that will help with the GABA receptor in order to prevent seizures and DTs. So there's ample literature revealing the utilization of propofol and dexmedetomidine for alcohol withdrawal. This slide demonstrates some selected literature utilizing the two and reinforces a lot what we already know as far as trends with these medications. So there is increased time on the vent with propofol and hypotension associated with its use. And then as far as Precedex or dexmedetomidine, there are decreased benzodiazepine requirements and then shorter time on the vent and in the ICU when compared to propofol. So one of the trials that I would like to highlight with dexmedetomidine looks at utilizing this medication for alcohol withdrawal in the ICU. And so this trial was done to evaluate the association between adjunctive dexmedetomidine for the initial treatment of alcohol withdrawal versus benzodiazepine. This was a multi-center retrospective cohort study done in 2012 to 2017. It included patients with alcohol withdrawal at an 8-hospital healthcare system and included patients as well who received dexmedetomidine within 1 hour of ICU admission. They did exclude patients that were intubated prior to or during the ICU admission, patients without a CWAS score, so a CWAS score of 0, if they died during their ICU stay or were direct admit from another facility or were transferred to another facility. The intervention was benzodiazepines alone versus dexmedetomidine with benzodiazepines. And they looked at ICU length of stay. They did find that their patients, those in the dexmedetomidine group, had a higher CWAS score at admission compared to those in the benzo group, possibly meaning that those patients had a higher alcohol use at baseline, and that was a statistically significant difference. But they did find also a longer ICU length of stay with the dexmedetomidine, which does make sense since it is an infusion that typically has to be tapered, and patients can't take that up to the floor with them. So dexmedetomidine and benzodiazepines do result in a longer ICU length of stay, but again, in this trial, patients did have a higher CWAS score in the dexmedetomidine group. So as for future directions, I would love to see this recreated, but maybe with more of a paired approach with CWAS scores to try to appropriately match the patients. And then of course, would love to see a randomized control trial. Next, we'll look at some promising alternatives. So we're going to focus on baclofen and ketamine due to time's sake, but there are a lot of other medications that are being investigated for utilization in alcohol withdrawal. The first medication we'll talk about is baclofen. So baclofen has various research that has been completed utilizing baclofen in addition to benzodiazepines to help augment treatment in alcohol withdrawal. And to summarize what the literature has shown is that there really is no large difference with CWAS scores when baclofen is added to the treatment regimen, but it does appear that it decreases benzodiazepine requirements, which is a plus. And the literature has really not shown any increased adverse effects when baclofen is added in addition to benzodiazepines. So something that could be kept in your tool belt. One trial that I specifically wanted to highlight was looking at high-dose baclofen with agitation-related events in the ICU. As we all know, agitation-related events can cause staff and patient harm. And so I think this trial is very interesting when working in the ICU with our patients that are extremely agitated. So they wanted to see if high-dose baclofen reduced agitation-related events compared to placebo. This was a multi-center phase 3 double-blind placebo-controlled randomized controlled trial, and this was actually done in France between 2016 to 2019. Now, one thing to note is that during the time of this trial, the French agency had a max daily baclofen dose of 300 milligrams, which they have now decreased down to 80 outside of this trial, but just something to note historically. They included patients that were 18 to 80 years old and who had an expected duration of mechanical ventilation for 24 hours or more, and also had a classification of unhealthy alcohol use by the National Institute on Alcohol Abuse and Alcoholism. This trial had various exclusion criteria, including baclofen use prior to ICU admission, or if they were unable to utilize baclofen due to hypersensitivity. And you all can refer to the rest of the exclusion criteria on the slide. So their intervention was a 1-to-1 randomization of baclofen to placebo. There was a loading dose on day 1, then followed by additional doses on days 2 through 15 based on the patient's renal function. Then starting on day 16, the patient had a gradual reduction in their dosing and then ultimately treatment discontinuation. The primary outcome was 1 or more agitation-related events during the treatment period, which they included as unplanned extubation, pulling out lines, catheters, drains, falling out of bed, fleeing the ICU and leaving AMA, which is never ideal, immobilization, device removal, or aggression towards themselves or towards staff. So there were a total of 314 patients, roughly split adequately, and there was no difference in baseline characteristics, but about 79% of patients were admitted for some underlying medical condition other than alcohol withdrawal, and they had a median alcohol intake of about 6 units per day. With the primary outcome, there was a decreased amount of agitation-related events in the baclofen group that was statistically significant. But the total number of agitation-related events between days 1 through 28, again, statistically significant for less in the baclofen group, but patients did spend more time in deeper sedation and also had fewer ventilator-free days. They also had a longer duration of mechanical ventilation and ICU length of stay in the baclofen groups, and all of those were statistically significant. So overall, high-dose baclofen might help control agitation-related events, but it does come at a cost. So longer duration of mechanical ventilation and deeper sedation, which is not an ideal outcome, but might be something to consider in the future. I would love to see future literature looking at this, looking at different doses, maybe utilizing lower doses versus high doses, and then also including patients that are not intubated. Next, we're going to talk about ketamine. Ketamine is an NMDA receptor antagonist, and it has been shown that high doses of ethanol competitively antagonize NMDA receptors, and during withdrawal, the unopposed NMDA receptors lead to excitatory symptoms. Therefore, NMDA antagonists mimic the effects of ethanol on the NMDA receptor at high doses, and so things like ketamine may be an alternative agent for alcohol withdrawal syndrome, especially when agents that are agonizing the GABA, such as benzos or phenobarbital, are not adequately controlling symptoms. So the trial that we're going to look at with ketamine evaluated the effect of using adjunctive ketamine infusions for symptom control in addition to lorazepam for patients with benzodiazepine-resistant severe alcohol withdrawal. This was a retrospective chart review in medical ICUs looking at patients with severe alcohol withdrawal from 2012 to 2014, and they included patients that used ketamine for at least an hour. They excluded patients where ketamine was used for another indication outside of alcohol withdrawal, or if they also received propofol or dexmedetomidine during the ketamine infusion. Their intervention, again, was using a ketamine infusion that was titrated to a sedation goal. And outcomes included time to symptom control, lorazepam requirements, the initial and maximum daily infusion rates, and then any adverse effects. This trial did only have 30 patients in it, and the mean time to ketamine initiation was about 41 hours. Typically, the ketamine infusion started at 0.75 milligrams per kilo per hour, and the max that they found was 1.6 milligrams per kilo per hour. There was, however, a significant dose reduction in lorazepam infusions, looking at about 4 milligrams less per hour, and that was statistically significant. Within 48 hours of ketamine initiation, 43% of patients were off all of their infusions, and no significant side effects were reported. So overall, ketamine may result in benzodiazepine dose reduction and provide additional symptom control with minimal adverse effects. In the future, I would love to see trials that look more at the ideal continuous infusion rate for alcohol withdrawal syndrome and ketamine. I would also like to see trials possibly looking at ketamine pushes, PRN, versus the continuous infusion. Also possibly looking more at early ketamine initiation rather than late, and then evaluating intubation rates, ventilator days, and ICU length of stay. So now we're going to move into the last little bit of the treatment overview, looking at fluid resuscitation, electrolyte replacement, and nutrition optimization as we close this bite-sized lecture. This is something that there's a lot of debate about, is what is the best way to fluid resuscitate this patient? How should we give them different nutrients? Should we do IV versus parenteral nutrition? What's the optimal dosing of thiamine and folic acid? And then one big debate that's still somewhat out there is to banana bag or not. So typically a banana bag, if you're unfamiliar with it, includes thiamine 100 milligrams, folic acid 1 milligram, magnesium and multivitamin, and then D5 or normal saline. As we all know, thiamine is very important with our pathophysiology, and unfortunately patients with chronic alcohol use will have malnutrition, decreased absorption of thiamine, decreased hepatic storage, and then also vomiting and diarrhea that causes them to not have great thiamine stores. So unfortunately, the worst case scenario of this could be Wernicke's encephalopathy, which can include things like confusion, memory disturbances, coma, ataxia, and ocular abnormalities, which is something we of course want to prevent for these patients. So looking more at how we give thiamine, do we give it oral? Do we give it IV? Orally, it has very poor bioavailability, and oral administration, therefore, does not do a great job of reaching the CSF. So to prevent Wernicke's, we really need to be giving IV thiamine. As for dosing, is 100 milligrams really enough? And literature has shown that no, when looking at its pharmacokinetic profile and short half-life, you really need more than just 100 milligrams once to prevent Wernicke's encephalopathy, and really need doses looking at 200 to 500 milligrams IV every 8 to 12 hours for about 72 hours to replete stores. As for folic acid, deficiency of this can cause megablastic anemia and other neurologic sequelae. And again, seeing the same theme, we really need to be giving IV administration of folate versus PO due to poor oral absorption with PO. Dosing for this, 400 to 1,000 mics IV daily, and you don't want to exceed 5 milligrams per day due to neurotoxicity. To wrap up our patient case, so on day 6, the patient was noted to be sedated to a RASS of -2, mumbling, confused. They were decreased in their benzodiazepine dosing. Day 7, their dexmedetomidine was stopped and further tapering of their chlordiazepoxide. Day 8, the patient was transferred out of the ICU and continued on their taper. And then on day 12, they were discharged with plans to follow up with addiction medicine. Just for everyone's reference, here's an example of an alcohol withdrawal syndrome protocol. You can give a loading dose of phenobarbital followed by benzos or further phenobarbital. Again, as Dr. Wright mentioned, this is a great utilization of phenobarbital with this dosing if that's something you would like to adopt at your institution. And then the adjunct therapy that is possible, things such as gabapentin, which we didn't talk about today, but has some promising literature, ketamine, baclofen, and then plus or minus dexmedetomidine and propofol infusions. And I think it's really important to emphasize that it's not necessarily always a one-size-fits-all approach. You will have to make some adjustments based on your specific patient. And I think that's what makes treating this disease state so challenging and exciting, is really trying to tailor your approach to the individual. So in conclusion, alcohol withdrawal syndrome is common in patients admitted to the hospital and proposes a significant burden on the healthcare system. While benzodiazepines have traditionally been standard therapy, recent literature suggests utilization of adjunctive or alternative therapies, such as phenobarbital or the other medications that we talked about. There is unfortunately a lack of large multi-center randomized control trials in the literature, and clinicians should recognize alternative agents available, especially in patients refractory to escalating doses of benzodiazepines. So with that, we are happy to answer any questions that you all may have, and we are very thankful for you all for coming to this presentation and allowing us this opportunity.
Thank you guys so much. If there's any questions, comments, please put them in the chat and we'll make sure we read them out loud for everybody and allow them to answer it. I have one question here, wanting to know the practice with phenobarbital use versus PRN versus target total loading dose when admission to the ICU.
Yeah, hi. I actually tend to use the St. Thomas protocol myself, which is the stepped out dosing. And again, if the patient's in active DTs, we will typically give the 240 milligrams IV loading dose. Rarely have to repeat that. And then if they're not in active DTs, we'll do prophylactic dosing. All those patients are in the intensive care unit for us. That's just our local practice for safety reasons. At least when I'm involved, we have had incidences where people have gotten over-sedated on some of those higher doses. So our current protocol actually does use the CWA scoring to kind of help you guide further dosing. So you don't necessarily give a dose if somebody's excessively sedated already. And we're happy to share our protocol here that we have. I think it's a pretty well thought out, pretty well developed protocol. Did that get to the answer to the question? I see another one. Are there any concerns with interactions with phenobarb? I always rely on my pharmacist to tell me that. The one problem where we do have it being used, unfortunately, by sometimes when it's probably inappropriate, is patients that are cirrhotic and have advanced liver disease. It probably shouldn't be used, at least and maybe there's an optimal low dose for those patients, but probably shouldn't be used in patients that have end-stage liver disease. Anything that you guys can think of?
Yeah, so there are some drug interactions with phenobarbital that clinicians do need to be aware of due to its induction that it can cause. So that's definitely something that needs to be considered if you have patients on a lot of medications. Definitely utilizing your pharmacist when able to ensure that there are no drug-drug interactions.
All right, I've got a couple more questions here. We've got one that says, what are your recommendations on if a patient should be discharged on benzos, gabapentin, etc.?
I'll be glad to answer that. We try to get our patients to follow up with addiction medicine here. That they often aren't interested in that, frankly. But we don't routinely discharge patients with benzos or gabapentin unless they are expressing an interest to go to rehab. We have bridged a few patients over the years with benzos.
And I think one other thing to add too with that is if patients were receiving phenobarbital in the hospital, it does have a nice self-taper that it does. Necessarily need to send them out with phenobarbital as it will continue to taper, although there is some literature that does look at that outpatient.
Got one more question here. What is your experience with Librium and what do you think about it?
I'll be glad to talk about that. I've used Librium and it works until it doesn't. It seems like there are patients that are have maybe a little bit milder case with DTs. It seems to work okay, and then if they are, I think it's worked for me prophylactically. And so I will occasionally use it. Again, it's hard it's one of these things. One of the nice things about the benzodiazepines, if you have an uncooperative patient who's agitated, you've got the IV route, which you don't have with Librium. I have had patients spit Librium out, literally at me, and to the nurses. So that's one of the limitations of Librium, I think. And we have one more question here in the room, Dr. Green.
So if a phenobarbital method is going to be implemented in your practice, do you use PRN therapy with a benzo or with a phenobarb push? And it might not be fleshed out with research, but is there a practice that you employ for breakthrough?
Yeah, a phenobarb push, preferably. Now, if they've already gotten their scheduled, then we'll use that lorazepam on top of that. And my own preference really is I'll start Precedex before I do lorazepam. I mean, I'm also on the IC Liberation Committee, and so I mean, I hate Ativan. So I really go to all sorts of efforts to avoid using lorazepam.
Well, thank you, everyone. It looks like I think that's all the questions. Really appreciate the speakers. Did want to mention this will be my last actual bite-sized lecture leading it. We are going to be transitioning to Kyle Brown from the clinical pharmacist at Piedmont, Atlanta, taking these over. So you'll be seeing more communication from him in the future for this. Thank you guys for everybody for having me. And thank you to our speakers today for making this an excellent presentation.
Thank you.
Thank you.